This is Dr. Weber reading his prostate cancer commentary for April 2023. The title is PARP Inhibition with Olaparib, a potential new indication for first-line therapy for metastatic castration-resistant prostate cancer. But first, the biology of inhibition of PARP, which is poly-ADP-ribose polymerase. Briefly, in the myriad of cell divisions, random mistakes are made in the faithful transcription of DNA into daughter cells. Some areas are of no consequence. They're called passenger mutations. Others can change the behavior of genes, often with deleterious effects, such as inducing cancer or increasing its aggressiveness. Of interest in this commentary are mutations that derange the normal function of the approximately 14 members of the BRCA, that's BRCA, family of DNA repair genes, notably BRCA1, 2, and ATM. The BRCA genes are the first line of defense, repairing damaged DNA. When mutations impair the repair function of the BRCA genes, the second line of defense for DNA repair is the PARP mechanism, which ensures the fidelity of DNA replication. The combination of BRCA malfunction and PARP inhibition, technically called synthetic lethality, is cell death. An estimated 6 to 9% of men carry a germline, that is to say, inherited mutation in BRCA2, and a total of about 11% have other BRCA family mutations amenable to olaparib therapy. The first PARP inhibitor to be FDA approved in January of 2018 was Olaparib, who has a trade name of Lynparza. This commentary presents the trial results that support the current use of Olaparib and introduces the PROPEL trial, which tested moving the combination of Olaparib and abiraterone to first-line treatment of metastatic castration-resistant prostate cancer. The early studies of Olaparib for treatment of men with BRCA mutations will now be discussed. Groundbreaking research by Matteo and colleagues presented at the New England Journal in 2015 established a role for the PARP inhibition with Olaparib in the treatment of men with metastatic castration-resistant prostate cancer harboring mutations in the genes BRCA1, 2, and ATM. In their small study of 16 heavily treated men, all 7 with BRCA2 mutations and 4 of 5 with mutated ATM responded. Overall survival for the biomarker-positive patients compared to those biomarker negative was 13.8 versus 7.5 months. The PROFOUND trial confirmed the effectiveness of Olaparib therapy in men with metastatic castration-resistant prostate cancer, presented by Hussein and Matteo. This study enrolled 387 men who had progressed to metastatic disease after standard ADT, such as Lupron, which was continued. Olaparib was then compared to either Zytiga, that's abiraterone, or Xtandi, that's enzalutamide, depending on which of the 2 drugs had been used following progression on ADT. One comparison was men who had mutations in BRCA1, 2, and ATM. The radiographic progression-free survival was 5.8 months for Olaparib versus 3.5 for Zytiga or Xtandi. Median overall survival at early analysis was 19.1 versus 14.0 months, respectively. A second comparison assessed the outcome of treatment for the entire study group and included the men with BRCA1, 2, and ATM mutations, but also those with one or more of the 12 other mutated genes in the BRCA family. The median overall survival was 17.5 for BRCA positive and 14.3 months for BRCA negative. An important finding, however, was that response to Olaparib was seen in all men with any BRCA family mutation. The PROfound trial results are the basis for the National Cooperative Cancer Network approval of Olaparib for men with metastatic castration-resistant prostate cancer with mutations in the BRCA family after progression on Xtandi or Zytiga. The next section discusses the PROPEL trial, which was advancing the PARP inhibitor Olaparib combined with abiraterone to first-line therapy for metastatic castration-resistant prostate cancer. As of December 2022, the FDA granted priority review of Olaparib abiraterone prednisone as first-line therapy for metastatic castration-resistant prostate cancer for men with and without mutations in the BRCA family. But first, what underlying biology supports this combination? Preclinical research identified that PARP activity is necessary for an activated androgen receptor to promote cancer proliferation, and that inhibition of PARP decreases the androgen receptor function. Additionally, it is thought that abiraterone may decrease the activity of some DNA repair genes. It was theorized that the combination of Olaparib and abiraterone could synergistically impair androgen receptor function, yielding an anti-tumor effect, and could benefit men regardless of mutations in BRCA. This was evaluated in the PROPEL trial. This trial tested the combination Olaparib, abiraterone, prednisone as first-line regimen compared with abiraterone and placebo in men with metastatic castration-resistant prostate cancer. And this was presented by Clark in the New England Journal of Medicine Evidence in June of 2022. The 796 men had progressed to metastatic disease after initial ADT. 87% had disease spread to bone, 32% to distant lymph nodes. ADT was continued after progression. Although mutations in the BRCA family were not required for eligibility, all men were assessed for the mutational status of the 14 genes in the BRCA family by the company Foundation One on biopsy specimens or circulating DNA. The aggregate prevalence of mutated BRCA2 was 9%, and mutated BRCA1 was about 1 to 2%. What were their findings? These were reported at about 50% of the estimated study maturity. 1, the median radiographic progression-free survival was 27 months for the Olaparib abiraterone versus 16.4 months for the abiraterone placebo, which was a 34% improvement. 2, the Olaparib abiraterone regimen benefited men with mutations and those without, as compared to the abiraterone placebo group, which was a 50% betterment for those men carrying the mutation. But also, there was a significant benefit of 24% for those men lacking mutations in the BRCA family. 3, the overall survival data was immature, but early analysis showed a trend favoring abiraterone and Olaparib in combination. 4, the commonest adverse effects exceeding 20% in the combined regimen were anemia, 46%, fatigue, 37%, and nausea, 28%. Grade 3 or greater anemia was more commonly seen in the combination regimen, 15.1% versus 5.3%. And pulmonary embolisms occurred in 6.5% versus 1.8%. No difference in cardiovascular adverse effects occurred between groups. The study concluded by saying, quote, the overall results of PROPEL demonstrate the clinical benefit of Olaparib in combination with abiraterone in the first-line treatment of a broad population of patients with metastatic castration-resistant prostate cancer, unselected for BRCA family mutations. So, the bottom line, if approved by the FDA upon complete review, the combination of Olaparib, abiraterone, prednisone will move to the pole position in the treatment of men with metastatic castration-resistant prostate cancer, regardless of their BRCA family mutational status.